My name is Ravi Mamtani. I am a professor and vice dean at Weill Cornell Medicine in Qatar. It is my pleasure to welcome you to our Population Health and Wellbeing series, which, as many of you remember, was launched last year. The objectives of the series are, number one, to discuss contemporary and critical topics relevant to healthcare, medicine, population health, examine evidence-based practices germane to public health and patient care, and three, describe opportunities and challenges in the evolving face of healthcare and population health. So before we kick off, some housekeeping notes. Your cameras and microphones are turned off. And please use the Q&A feature to type questions and comments that you may have. Questions, of course, that come from you and the audience or others will be addressed at the end of the session. So, like in previous times, this activity is accredited by the Accreditation Council for Continuing Medical Education in the US, and also by the Continuing Medical Education program of the Ministry of Public Health. And we designate this activity for a maximum of 1 hour. So the post activity evaluation will be available in your Cloud CME account by August the 20th, 2021. You will receive an email notification once the evaluation is available in your Cloud CME account. Your certificates will be available for download once you complete the post-activity evaluation on the Cloud CME portal. So we have an extremely important topic today. As you know, that COVID-19 has really turned things upside down worldwide. And one such activity that's been affected is the research activity in healthcare institutions. So we thought it would be timely to introduce to you and to the audience a topic that we call optimizing public health research during the COVID-19 pandemic. And of course, in this, we have our colleague, Dr. Sohaila Cheema, who will talk about experiences at Institute for Population Health at Weill Cornell Medicine in Qatar to bring some views forward and hopefully maybe have you reflect and ask us questions and comments at the end of the session. So, as I said, our speaker for today is my esteemed colleague, Dr. Sohaila Cheema, and I'd like to introduce her briefly before we move on to the discussion. Dr. Cheema is the Assistant Dean for the Institute for Population Health and Associate Professor of Clinical Population Health Sciences at Weill Cornell Medicine in Qatar. She actively participates in oversight and implementation of Institute's educational, research, and community programs. She also directs several courses, both in the pre-med and the medical student education program. Dr. Cheema serves as faculty and course director for several continuing medical education programs and activities, including two very important courses, namely Certificate in Lifestyle Medicine and the other one, Understanding Basics of Health Research. She's also the co-founder for the Lifestyle Medicine Interest Group. As many of you know, that Cornell in Qatar has an interest in promoting lifestyle medicine in the region, in the country, in the region, and worldwide. She has collaborated with private and government institutions to promote health awareness in Qatar and the region. Her research interests include non-communicable diseases, chronic illnesses, migrant health, oral health, road traffic injuries, integrative medicine, lifestyle health, and more recently, issues surrounding the COVID-19 pandemic. She's extremely wide, and just a quick glimpse of her accomplishments. She received a medical degree from Dow Medical College in Pakistan and completed a fellowship in integrative medicine at the Arizona Center for Integrative Medicine, University of Arizona. She also received a Master's of Public Health from Johns Hopkins School of Public Health and is certified in public health by the National Board of Medical Examiners in the US. And I might add, she is a diplomat of the International Board of Medicine. So with that brief introduction, I'd like to invite Dr. Cheema to the virtual podium, and please join me in welcoming her. Thank you. Dr. Cheema, over to you.
Thank you, Dr. Mamtani, for those kind words. Okay, so I'm just going to focus and talk a little bit about optimizing public health research during the COVID-19 pandemic. So I wanted to wish all our participants assalamu alaikum and good evening to all of you, wherever you're joining us from. So this is my disclosure statement. I don't have any financial relationships to disclose, and I will not be discussing unlabeled or unapproved use of drugs or products. So moving on to the objectives for the talk today, this is what I will try and do today. We're going to review the public health research challenges which we encountered during the pandemic and what we identified as new public health research opportunities. And then we'll summarize recommendations and some future implications from our research that we did. So just to give everybody an overview of what we do here at the Institute for Population Health. The Institute for Population Health was created with the mandate to promote education, research, and community initiatives. So we basically develop, implement, and support education and capacity building along with population health research and community programs, plus activities which are aimed at really reducing premature mortality, preventing chronic disease, promoting health, and improving the quality of life for the population in the state of Qatar, the region, and beyond. So the Institute's guiding principles are as follows. They basically ascend from the Qatar national vision, and they're aligned with the QNV, the national strategies, and the public health strategies of Qatar. We collaborate with both local and global partners to engage in population health research. We support student and healthcare professionals' education in public health, lifestyle medicine, and we support community outreach by fostering the development and implementation of programs aimed at population-based health promotion, research, and disease prevention. So we also follow the same principles for our research. We have a collaborative research focus looking at problems of population health importance. The emphasis is on the social determinants of health and disease, prevention, health promotion, and quality of life improvement initiatives. So also looking at improving public health policy and building capacity in Qatar. So our research publications, for those of you who may not know, are available on our website under these broad thematic areas. I'm just going to give you a few examples of some of the work that we've done previously, pre-COVID, in research and how that helps with our focus and our aims. So this was our work which was published in Injury Prevention. It was titled Motor Vehicle Injuries in Qatar, Crime Trends in the Period 2000 to 2010. And it basically showed that speed cameras and other interventions that were implemented by the government of Qatar, they help reduce motor vehicle fatalities and injuries. This was another observational study, a cross-sectional study that we did on seatbelt use and mobile phone use among vehicle drivers in the city of Doha, Qatar. And the conclusions out of this research were that 3 out of 10 drivers in Doha did not use a seatbelt, and 1 in 12 were using a mobile phone while driving. And the recommendation was that awareness campaigns and increased law enforcement is required. Here is another study in which we looked at the cancer risk in water pipe smokers. It was a meta-analysis which we conducted, and it was basically informative both for the community and for the policymakers to show that yes, shisha or water pipe smoking is associated with cancers of head, neck, the esophagus, and the lung. Here is another study which we looked at physical activity and sedentary behavior in the Middle East and North Africa region. It was an overview of systematic reviews and meta-analysis. And we basically initiated this to support the global strategy to reduce risk factors for obesity. And we synthesized the data that was available. When we synthesized the data, we saw that the global epidemic of insufficient physical activity, it's also prevalent in the Middle East and North Africa region. So 50% of adults and 75% of the youth in the MENA region, they are basically not meeting the recommended international guidelines for physical activity. Also, physical activity participation among youth and specifically females have to be addressed by focused lifestyle interventions. The recognition of sedentary behavior as a public health issue, it still needs to be studied because it's still unclear because there is no clear standardization of sedentary behavior as an issue. And additional data was required on physical activity behaviors from low middle income countries in the region. This was a follow-up study which we published, and we looked specifically at barriers and facilitators which were associated with physical activity in the MENA region. And the recommendations coming out of this paper were basically to have interventions which promote physical activity in MENA. They should target school children, women, girls, working parents, and the elderly. And what was very important for the MENA region is that country-specific socio-cultural and environmental factors which influence physical activity should be considered in the design of interventions. And again, current and future policies and national interventions must be consistently evaluated for effectiveness and desired outcomes. So as you see, with some of the examples that I shared with you, the Institute's research, it basically bridges the gap, which is relevant to public health and epidemiological data. It addresses public health challenges and provides evidence-based recommendations to inform policymakers on a wide range of healthcare-related issues. And then this is what hit the world. COVID-19 came, and with the onset of COVID-19 pandemic, we all know it caused very high mortality and morbidity and continues to do so worldwide. Lockdowns were imposed very, very quickly for most countries in the world. And this led to movement restrictions, travel restrictions, quarantine, isolation. Hospitals and clinics were only receiving emergencies. At the same time, in tandem, there was an infodemic happening about misinformation, myths, and perceptions, what people had about the COVID-19, and it was leading to mass confusion. And the confusion has still not cleared, as you all can see with all the media stories and all what keeps appearing on social media platforms. Along with this, there was massive social disruption. Schools closed down, colleges closed down, there were disrupted routines and schedules, and all employees were asked to work remotely from home. Now, of course, this led to impediments for research. Why? Because there was restricted patient contact with the healthcare delivery systems. In-person contact for us with patients who are our consumers was not possible. We could not conduct, for example, patient interviews, in-person self-administered surveys. And the other thing was employees were also working remotely from home. Collaborative approaches, which are generally happen in person, it became a challenge. And there was decreased number of analytical, descriptive, and experimental studies like randomized controlled trials. So we all know that research really lies at the heart of any academic institution. The drive to discover, to create new knowledge, and to impart it is often what really motivates university researchers to choose academic careers. And we know that research leads to the creation of new knowledge. It allows scholars with different disciplinary backgrounds to engage, to debate, and share thoughts. So how did we move forward? What did we do? So we really saw this at the Institute for Population Health as a window of opportunity to use technology methods which would not require data collection in person, to use existing information like published literature, already existing data, and to explore innovative ways to engage in research. And some of the mechanisms that we used were to write letters, to debate on topics, continue with systematic reviews and meta-analysis, which we were conducting, write up short communications, viewpoints, or commentaries, and also engage in scoping reviews. So we identified research opportunities and we explored contemporary public health research topics. Some of the topics that we explored was stress among nursing students, among college students. We looked at depression among healthcare workers. We looked at the effectiveness of face mask use. We looked at the geriatrics and elderly population. We looked at the topic of telehealth, public health. What were the implications of school closure and lifestyles? What was the impact on lifestyles of people during COVID-19? So coming on to the third objective about summarizing recommendations and findings from our research work and future implications. I'm going to highlight just some contemporary population health and healthcare research topics, keeping in mind the time limit that we have. So in the next 20 to 25 minutes, I'll focus on these topics and share with you the work that we did on these topics. I'm going to start with our research on elderly people. Early on, we published this letter to the editor on older people and epidemics, a call for empathy, and then a commentary on respiratory epidemics and older people. As you all may know, older people are generally more susceptible to epidemics. So we already know from annual seasonal epidemics, from the SARS and MERS epidemic. Older people are also a very special group, and with increasing life expectancy worldwide, the population among the elderly is definitely growing. The impact of COVID-19 disease was particularly severe amongst the old people. This was seen worldwide from the onset of the pandemic, and nursing homes and care homes were particularly effective. And I think what was really important for us to remember that the lives of older people are important and precious as any other physiologic age group. What did we find? Yes, there is vulnerability of older people to epidemics. So again, there are many different areas that you can see: demographic, biological, social, healthcare, behavioral. So again, with all these things which is happening, with age, we know there is dwindling immunity. The aging process and existing comorbid conditions, which may be there in elderly people, plus there is cognitive decline. Now with cognitive decline, it also leads to a reduction of the speed of processing, cognitive flexibility, the capacity to draw inferences from a variety of information, and it reduces the ability to focus. So what were our recommendations out of those two papers regarding the elderly? So we definitely need to provide justice to our elderly, preserve their health and dignity. We must work with our elderly people. We must learn lessons and plan accordingly. Government policy, health, social care, and the wider society really needs to look after the elderly. Social ties are very important. We have to make sure we prioritize healthcare access and healthcare delivery to our elderly population. And we should also focus on impoverished communities. So resources must be assigned for those communities. Leadership, guidance, National Geriatric Society, healthcare practitioners, civil society, academia must all contribute towards the needs of the elderly. We must enhance education programs for healthcare professionals and include topics which have been neglected in the traditional curricula. One thing which was very clearly highlighted during the pandemic was about messaging to the elderly population. We must avoid any kind of messaging which may overwhelm or confuse them. Health campaigns and messages must be tailored for their needs. It should be limited, focused, and unambiguous. And we should be utilizing stories or illustrations as opposed to complex data, statistics, or scientific explanations. Then we must also strengthen the collection and analysis of data so that it can guide programs and policies to protect and care for older people. Yes, COVID-19 has created upheaval and it has challenged humanity and threatened the lives and rights, but we must all ensure that we remain an age-friendly society, and we must make it inclusive for our older people also. We looked at some research, we did some research on face masks use during COVID-19. Again, if you all remember, so this was the study that we did. It was a rapid review and meta-analysis. And basically, we synthesized the information which was available on the effectiveness of medical and cloth face mask use by the general public in community settings. So we all know that in general, even in the beginning, there were consistent recommendations by international organizations like the CDC and WHO about mitigation measures like isolation of infected individuals, quarantining close contacts, regular disinfection, physical distancing, and hand hygiene. But about the face mask, controversy continued. So after several months of deliberation, since the pandemic started last year, the WHO, after several months only, then recommended that face masks should be used where you have people in public transport, on shops, or in confined spaces. What were our key findings from this paper? So these were our key findings. Medical face masks, they should be used by healthy individuals for preventing respiratory infection transmission. They must be used by sick individuals for preventing respiratory infection transmission. The very important thing was it must be used in combination with other preventive measures. So again, with physical distancing, with hand hygiene, all of these have to be used together in order for it to be effective. And its effectiveness is dependent on compliance. So as we know, in Qatar, we still continue to use medical face masks for our protection and to help reduce transmission. But there was no evidence, direct evidence, that we found in our research in humans for the recommendation of cloth face mask use. Here was another study that we did. It was published in the International Journal of Environmental Research and Public Health. And we looked at knowledge and anxiety about COVID-19 in the state of Qatar and the Middle East. It was a cross-sectional study. And initially, when we started thinking about this, no one really knew that this was going to be a worldwide pandemic. And we were going to do self-administered surveys in person, but of course that did not happen. We again shifted our methodology and we did a part of the study online through social media platforms where we requested the general public to fill this survey out for us. And again, the idea behind this study was that we know that there were questions and there were confusions regarding various aspects of the COVID-19 disease. Example about their symptoms, the management, the modes of transmission, the availability, efficacy, and effectiveness of the available vaccines. We know that there was misinformation and disinformation spreading at an alarming rate. And again, that was leading also, and it led to civil unrest and protests against governmental measures which were implemented to curb the virus. And it really facilitates misinformation and disinformation, really facilitated the spread of conspiracy theories and prejudice. So we wanted to look at baseline knowledge and perceptions towards COVID-19 among healthcare workers and the general public. So what did we find? So these were the findings that we got from the study. This was about the knowledge, and we found that the knowledge of healthcare workers about COVID-19 was good during the early stages of the pandemic in Qatar. So even though, of course, COVID-19 was novel and there were many unknowns, healthcare workers were not frightened about COVID-19. Now, this is a really important finding and an important aspect in outbreak control, because our first responders have to be aware of the risk posed by the disease and what the precautions are that are required. And they should neither panic and nor be preoccupied with fear. So without the consistent efforts we know of the frontline workers during the COVID-19 pandemic, the world would not be what it is now. So healthcare lives that were lost early on in the pandemic, in many instances, it was not because of lack of knowledge, but it was really about the non-availability of timely personal protective equipment rather than negligence on their part. So healthcare workers had better knowledge than the general public, about 63% versus 30%. And the knowledge was higher in females and older respondents and nationals from Europe or North America, and more educated respondents, and in healthcare workers and teachers. And the general public, as you can see, this was the finding, relied mainly on social media for information about the pandemic. And as we all know, this has really perpetuated the problem, of course, about the pandemic, its spread, the knowledge that we have, and now about vaccine hesitancy also. What did we find about anxiety from our survey? So we found that most healthcare workers, they were slightly anxious, and their anxiety was mainly fear of transmitting COVID-19 to their family or others. So that was the common source of anxiety among them. Whereas for the general public, they were very anxious or really frightened. So about 28% versus 12%. They were worried about getting the disease. They were worried about being quarantined or dying from COVID-19. So high levels of anxiety were found in groups of females, younger respondents, respondents from Asia, Africa, residents in the GCC countries, people who were somewhat less educated, employed persons, homemakers, and students. Now, the study really helped address the misinformation crisis. And some of the things that we recommend is this, that of course, the COVID-19 pandemic continues to teach us important public health lessons. Communities, if they are empowered with correct knowledge, they should be, because then they will make evidence-based decisions to really protect themselves and their communities. We must address panic, any unfounded anxiety, and casual and carefree attitudes, because this can really increase risk-taking and mistake-making, and it increases people's vulnerability to the infection. There's a huge role of government, public health agencies, and healthcare workers and civil society organizations. And they must always keep themselves updated on scientific developments and then transmit these messages to their communities in an honest, transparent, and unbiased and timely manner. Health institutions and stakeholders, they should also keep their healthcare workers updated with evolving information, with protective measures, because we know that if there's unaddressed anxiety among healthcare workers, it can really undermine the public health response to the pandemic. We also saw from the survey that there are several unknowns as to why people react in the way that they do in a crisis such as COVID-19. And of course, this provides us additional scope for exploratory research to understand human behavior and the drivers of their actions during a pandemic. The next topic I would like to share some with you, some findings from it, is about telehealth use during COVID-19. So we conducted 2 studies on telehealth. So this is the first one that I'm going to share. And this was a review, a scoping review and evidence synthesis that we did about telehealth use in geriatric care during the COVID-19 pandemic. Of course, globally, we know, as I said and alluded to earlier, COVID-19 pandemic affected older people disproportionately. And prior to the pandemic, there were reports already of telehealth being efficient and an effective form of healthcare delivery, particularly for older people. Now, during the pandemic, of course, there was an increased use of telehealth, and a large amount of published literature was coming out on this topic during the pandemic. So we said, okay, let's conduct a scoping review and synthesize the evidence for telehealth use. And this was focused on the geriatric population, and we wanted to see what do we learn from this new data which is being published. So if we looked at the medical specialty and subspecialty and specific disease conditions, it was being used very widely. As you can see, from psychiatry to neurology to internal medicine, surgery, dermatology, preventive medicine, urology, urogynecology, pulmonology, and general care medicine. So it was being used by several specialties. So what we also did, we looked at all the articles and we did a SWOT analysis. So basically, we looked at the strengths, the weaknesses, opportunities, and threats. So I'll just go over some of the strengths, weaknesses, opportunities, and threats that we found. So the strengths of using telehealth in the geriatric population were as follows. Basically, it avoided overcrowding in health facilities. There was reduction in long distance travel. It minimized the risk of serious events such as falls. It improved resilience, well-being, and we were able to perform assessment in the living environment of the older people. There was reduced loss to follow-up, and it promoted social connectedness among nursing home residents in particular. What were some of the weaknesses? Basically, with telehealth, it was difficult to treat patients with cognitive impairment, if they had visual acuity issues and hearing problems. There was limitation in physical examination, including gait assessment, which can be very important in our elderly population. There was a basically difficulty, with video connectivity. So that was a problem. Maintenance of equipment. There was lack of privacy for older people because they may not have a private space where they could be doing their telehealth conference from. And then there was lack of familiarity of healthcare professionals basically with using the telehealth platforms because they have not been trained as much in telehealth. But let's look at some of the opportunities it provided. So there was free communication platforms. So that was really a fantastic opportunities. Digital photographs, asynchronous sharing could be done to circumvent any connectivity issues. There was enhanced integration of specialty expertise cares in nursing home residents. And then what we also saw during the pandemic was that wearable devices and remote monitoring sensors, they were being used as early warning tools. So technology basically that is easy to understand pertaining to the interface, passwords, and maintenance is easy to use. Let's talk a little bit about threats. So of course, the ambiguity and technical jargon which was used for descriptive terms was a threat. Variability of the available telehealth platforms. There were so many different platforms which were available. And then in some countries, there was lack of sustained insurance reimbursements. And then digital divide was obviously present. Lack of equipment, limited literacy, and lack of assistance to use telehealth platforms. And technical failures and patient dropout also occurred. When we looked at, what we also did was, we said, okay, let's see what is it being used for. Is it being used for preventative services, curative, rehabilitative, or general? So again, these little circles basically just stand for, we color-coded them. The green circles were for case studies. The blue circles, they were for literature and scoping reviews. And the yellow circles were really opinion pieces, reports, editorials, and recommendations and perspectives. So the number of circles, the small circles, it represents the number of articles of the specific category. So you can see, yes, they were being used for curative, for general, and also for preventative and rehabilitative purposes. So we also made recommendations for improving telehealth services for older people. We basically divided these into 4 major categories. For older people and caregivers, for this group, we said communication technology training is essential. Informed decision must be used to use telehealth. We must discuss concerns with healthcare practitioners, explore solutions to mitigate concerns, and be involved in standardization of telehealth use for geriatric use. Then in the category physicians and other healthcare providers, training is required to assess patients using video conference. Digital tools, digital versions of the screening and diagnostic tools are required for physicians and other healthcare providers to really maximize on this, on telehealth. Then asking patients about concerns and barriers to access technology, and redirecting really patients to educational community resources. Then there's technology and governance and health systems. And of course, for technology, we can really develop automatic speech analysis, improve technology to accommodate age-related sensory cognitive impairment, and develop larger touchscreen tablets and so on. And in government and health systems, we definitely need to do educational outreach, sanitization of the telemedicine equipment, integrate telehealth use in training curricula, which is very, very important for both healthcare and social care, provision of equipment like tablets and internet, because if we don't ensure free internet service to all, including old people, the telehealth platforms will be useless. This was another study that we did. It was a scoping review of telehealth basically during the COVID-19 pandemic. So here we found in the first 6 months of the pandemic, about 550 articles were published. Most of them were in English, 61% were opinions, commentaries, perspectives. 87% were basically authors from the US. One thing which came out very clearly, that several definitions were being used to describe equivalent terms to telehealth. And then again, 8% of the articles focus on the provision of COVID-19 related care, 50% on the different components of clinical care, and 23% on various specialties and subspecialties of internal medicine. What we also did from these articles was that we categorized and we did a classification of sentiments on telehealth used by the practitioners, so by the authors who used it. So there were 3 sentiments that we used. And again, this was based on a framework. The sentiments were celebratory, contingent, and concerned. Now celebratory, they were 84%, and celebratory really just means that the authors provided a positive appraisal of telehealth use during the pandemic. Contingent is where the authors recognize the positive potential contribution, but they also acknowledged its potential limitation. And in the concerned sentiment, the authors identified challenges and they cautioned on the imbalance that telehealth may create in healthcare delivery. And the contingent and concerned sentiment, where the authors expressed that, they said that there was more evidence required on patient satisfaction, cost effectiveness, efficacy, accuracy of care, and health equity. And these are the conclusions. Yes, telehealth has a role in advancing healthcare, But we must look at feasibility and application of telehealth in resource limited settings and low middle income countries, because we believe in health for all. A global consensus is required urgently on definitions, boundaries, protocols, monitoring, evaluation, and data privacy. And robust evidence on the safety and effectiveness of telehealth is also required. There's a huge breadth and depth of data which is currently being generated. So there's a large scope for systematic reviews and meta-analysis for the future. And also healthcare professions, curricula, plus CME and CPD programs must include telehealth training. Moving on to look at some lifestyles and what the effect of lifestyles was on because of the COVID-19 lockdown. So we did a narrative review. I'm just going to show you some of the findings that we had, that while we know that COVID-19, of course, led to negative factors, like non-availability of vegetables, food, reliance on processed food. There was closure of gymnasiums and parks, so limited time for physical activity, excess screen time and stress, boredom, anxiety, domestic violence, family tension, loneliness, and social isolation. But it also provided opportunities for people, positive factors. People started shifting to home food, explored new opportunities for remaining physically active in a home environment. There was an opportunity to regularize sleep cycles and reduced availability and motivation to quit. This is a negative factor that we had, I'm sorry. Increased family time was there, and then there was also an opportunity for acts of kindness, like social connectedness. And how can we really do this? So we know that if we maintain healthy lifestyle measures, it helps reduce chronic disease risk and improve immunity. So by managing stress, by healthy eating, focused on plant-based diet, whole grains, trying to remain physically active in the home environments or in the environment that was possible, quitting smoking and harmful substances, optimizing good sleep hygiene, and then maintaining social connections virtually, like with videos or phone calls with families and friends. And these were our conclusions. We know that WHO has identified that COVID-19 pandemic has really thrown the global health progress on NCDs already off track. So we must promote healthy lifestyles with an emphasis on disease prevention and self-care. We must augment public health curricula, professional health curricula, with evidence-based public health practices and lifestyle medicine. Plus, healthcare systems must address the holistic needs of local populations before, during, and after crisis situations. And again, this is also an opportunity in schools and undergraduate college education to integrate basic health, infectious disease, and lifestyle education. So here was another recent commentary which we published. It was about in the American Journal of Lifestyle Medicine, and it was titled "Scoring Lifestyle Medicine Goals with FIFA 2022: An Opportunity to Strike Big," where we basically promoting the idea that the FIFA 2022 should be used as a flagship event to promote healthy lifestyles, to prevent, treat, and reverse non-communicable diseases, and really promote the field of lifestyle medicine. These were some of the recommendations we make in the commentary: to establish clinical lifestyle medicine programs, to use famous soccer stars to promote healthy lifestyles, and so that they can champion lifestyle medicine, promote soccer to not only the youth, but also to middle-aged and older people, support lower impact forms of soccer for older people, and also recommend that there should be routine collection of sport-specific health data as part of national health surveys. Again, the final recommendation is very, very important, where schools and colleges can actually play a pivotal role in promoting healthy and active lifestyles. We also did one study looking at school closure during COVID-19. So we looked at child and adolescent health, and these were our findings. So as you can see here, there was a decrease when the schools closed down, there was a decrease in hospital administrations and pediatric emergency department visits. Access to school-based healthcare services decreased, and also access to school-based special services for children with disabilities. There was also reduced access to school-based nutrition programs. What we did see an increase in the period that we conducted the rapid systematic review was that there was an increase in body mass index, which means that there's increased likely childhood obesity. Then there was an increase in anxiety, loneliness, stress, sadness, frustration, indiscipline, and hyperactivity. So again, the negative impact basically was on school-based critical services and resources, particularly for children with disabilities and those living in poorer families. So we really need to identify children and adolescents with a higher risk of learning and mental health impairments, and we have to support them during school closures. And again, benefit and risk assessment from school closure should be custom tailored, and it should be specific to the local socioeconomic context, the health system, and school resources. So coming last but not the least topic. So we highlighted during the pandemic, again, the importance of public health. So we published several commentaries, but again, I'm going to just highlight a couple of them before I close the session. So this was the first one, and we titled it The COVID-19 Pandemic, the Public Health Reality. So again, of course, we know that there are going to be medium and long-term health outcomes for communities from the mitigation measures. We've already seen colossal social, economic disruption worldwide, misinformation, confusion. If we have contrasting expert statements and lack of international coordination, it really leads to influencing public perception, and there's increased fear, uncertainty. And our key messages are this: we do not downplay or overstate any pandemic risk. Those who are at an increase, they should definitely receive priority and be managed effectively. A timely, coordinated, evidence-based approach is necessary from the international community. Scaling up of health systems must be considered in planning. Sensational reporting and misinformation, we've seen a galore of that. It must have gatekeepers. Decision-making, it must be based on science, public health evidence, and we call for responsible journalism and communication. And again, we focus and say again that public health education in school, community settings, and colleges must be imparted. Here was another paper that we published. It was called The Single Most Important Lesson from COVID-19. It is time to take public health seriously, published in the Journal of Global Health. And again, here we looked at 3 domains. And we said, okay, let's look at the commitment to public health in the last decade. And we focused on these 3 domains. We looked at medical education, investment in public health, preventive programs, and public health research. So in all 3 domains, we found that it was adequate training, plateauing or stagnation of investment, and inadequate allocation for funding public health research. We definitely have to scale up all of these investments in all these 3 domains for us to move towards a better and improved world. So we've seen that COVID-19 has highlighted the shortcomings of inadequate emphasis on public health education, policy, and research worldwide. We must advocate for the role of public health in policy formation, community education. We must strengthen public health curriculums in medical education, other healthcare professionals' education, and increase investments. And this complacency, which has been going on for so long, that public health is not important, is not right. It is really time now to take public health seriously. Just a few lessons that we've learned for future research. So again, it is really important for us to maintain research quality, as we have always done. So we will always define priorities about research. Our methodologies should be rigorous. Analyses must be conducted with integrity. And researchers really need to establish better ways to ensure trusted community with the public. So here, in the difficult times, we really need to be more prudent though. We really need to publish to ensure that the society understands our research and understands the results and the benefits. And we must ensure that publishing our research, we should do so clearly, accurately, and honestly. And I think this quote from this paper that I read is really, really important. We write to be understood, but perhaps more importantly, we should write in a manner which ensures that we are not misunderstood. So again, we have to recognize that there's no single discipline that can resolve all problems that have arisen. We must have, for successful outcome, inter and transdisciplinary collaboration, partnerships, social responsibility. Acquiring and storing research data will become increasingly important, but more so the ethical issues which surround access to data and particularly personal information. We also know that artificial intelligence is becoming increasingly effective, but we need to conceptualize the ethical use of information in different ways. Pandemics, have they ended? No, they will occur in the future. We must learn from the COVID-19 experience to make an informed and integrated approach for required research. So this is a pertinent quote I wanted to share in the end in the current context. So our research must also change, just like the quote says. It is not the strongest of the species that survives, nor the most intelligent that survives. It is the one that is the most adaptable to change. So my dear healthcare professionals, our research in this situation and in the different contexts must also change and adapt, and it must be custom tailored to the situation. That is how we will succeed, and that is how we will survive. So before I end, I would like to thank the IPH research team, which is led by Dr. Mamtani. We also have Dr. Karima, Dr. Amit Ibrahim, Ms. Anupama Jitesh, some of our former colleagues at IPH, Dr. Sonia Shaban, and Dr. Satya Doreswamy. I would also take this opportunity to thank all our collaborators, starting from Dr. Javed Sheikh, our Dean at Weill Cornell Medicine-Qatar, Dr. Ahmed Al-Mullah from Hamad Medical Corporation, Dr. Marco Amaduri is also a Senior Associate Dean for Pre-Medical Education and Education City Collaborative Curricular Affairs, Dr. Albert Lowenfels from New York Medical College, Patrick Maisonneuve from the European Institute of Oncology, Milan, Dr. Ingmar Weber and Jison from QCRI HPKU, Qatar, our WCMQ students who contributed to the research process. I also wanted to mention all our articles are open access and they're available on our website. And we also support, in addition to doing research, we support education and training in Qatar among healthcare professionals. And two of the workshops or the programs that we have currently ongoing, which are there available to strengthen and augment research skills among healthcare practitioners in Qatar and the region, our systematic review and introductory workshop. And this is happening again, if you're interested, on September 3rd and 4th. And then the understanding basics of health research, which is also happening September 18th and 19th. So I just wanted to highlight those two before I end. So thank you for listening.
I want to thank all the participants for their interest, for their comments, their questions. And we were delighted to have you participate in this discussion. And of course, we have additional exciting programs in this series in the months ahead. So stay tuned, and we wish you all the best. And once again, on behalf of IPH at Weill Cornell Medicine-Qatar and on behalf of Dean Sheikh, thank you for joining us. It's been a pleasure interacting with you all. So shukran, thank you, and have a wonderful day.